If I think about all the mistakes that I must have made over the years and all the advice I've been given over the years and what I would wish other doctors to either do or not do, if I'm trying to frame it for someone, I'd probably just walk them through a skin cancer check and say, from the moment the person walks in the door to the time they leave the room, there's many opportunities to do something just that little bit better than everybody else, or just avoid doing something in a way which is going to offend somebody. The second someone walks in the door, sure, you greet them. Don't forget to ask them what has brought them to your door. You might assume that they're just here for their routine skin check, but sometimes they surprise you. And this is one of the first things you get taught. But once you've been doing skin cancer medicine for a while, you sort of get into a groove where you think, oh, I'll just do my skin check and all the rest of it. But the number one important thing that you need to know is what has brought the patient to your door. Over half the melanomas that get found are found by the patient. Now, if you haven't ever met someone before, it's twice as important, because if you've met them 12 months ago for the skin check, well, you know that whatever they've got is only going to be fairly small, or at least only 11 and a half months old since you last saw them, or 5.5 months old since if they're on a 6-monthly check schedule. So have a good look. Some doctors haven't let their patients know that it's not all about moles. Only a quarter of melanomas were ever a mole, which means if, as happens to plenty of Australians, someone grows a melanoma, that person now has a roughly 5 times greater risk than everybody else of growing another melanoma. We have to let our patients in that category know that it's not just their moles that they have to now keep an eye on. They should be more worried about the new spot that doesn't quite look like a mole than they should their mole that's been sitting there unchanged for 50 years. And then they say to me, well, how am I going to know if something new comes up? And that's when you start having the conversation about self-checking. Check your own spots. Check monthly if you've had a melanoma and look for subtle little tiny things. And I have had patients come in and say, Hamilton, this was not here 6 weeks ago. And they're right. Patients have found 1.4 millimeter melanomas. Sometimes a melanoma just sounds like a melanoma. All these decision-making algorithms we've got, they're not perfect. They don't catch 100% of melanomas. So you've got to listen to what patients say and the timeline of what they're describing. Because if the story is just wrong for all the safe things you can think of, they've told you a story potentially of cancer. So you owe it to them to explain to them that, look, that timeline is not the story of an age spot or a freckle. That concerns me, and it would be my preference to do a biopsy in this instance, if that's all right with you. What else have I done over the years that I wish I hadn't, or what has someone told me that I'm glad they did? Well, we've had don't talk yourself out of doing a biopsy. Some melanomas just sound like melanomas. No decision-making algorithm is perfect. And a good one is people who grow melanomas grow melanomas. If you need to identify in your practice software which of your patients have already had a melanoma, because they are probably 5 times more likely than all your other patients to grow you more. They're the patients you should worry more about. What I like telling patients who are incredibly anxious, if the patient's focusing too much on the fact that they've now got a greatly increased risk of getting a melanoma, and that even though it was a level 1 melanoma with no roots that has 100% survival, they're still just beside themselves, perhaps we could rephrase level 1 and call it stage 0. I don't want to minimize their diagnosis of melanoma, because a well-motivated patient finds their own melanomas. But we mustn't give our patients health anxiety in the process of trying to make their lives better. So yeah, stage 0 melanoma is a phrase I like bringing out for the patients who are just beside themselves. Sometimes the clue poor melanomas have an element of pinkness to them. And if you talk to colleagues who are skin cancer doctors, they'll have a few little memory tools about skin cancer. And one of them is pink with brown makes you frown. If it's pink in a sun-exposed area and hasn't gone away within about 6 weeks, it's probably not inflammatory, meaning it's not an eczema and it's not a pimple. So, pink with brown makes you frown. When you see pink, stop and think. That's another good one. So, especially when pink has been there for a while in the same place that's sun exposed and hasn't gone away. Those two things will find you a lot of non-melanoma skin cancers and a few early melanomas. I also tell patients that if it's sandpapery in a sun-exposed part of your body and it won't go away by itself with moisturizer and sunscreen, that's possibly precancerous. How precancerous? Well, why don't you show it to me, or at least make a list and make sure you show it to me next time you're here for your routine skin check. If a scaly spot that's been sitting on you for a while and you've had it on your list to show me at your 6 monthly check develops tenderness, bring your appointment forward, okay? So those three things, to be able to tell a patient in the space of about a minute, can be a good exit strategy for saying, look, it's not, I can't tell you everything I've learned over the last decade of medical school and how to cut out skin cancers, but I can give you these 3 tips. And then go through your pink with brown makes you frown. When you see pink, stop and think. Scaly things should go away within 6 weeks. And if you've got a scaly spot that's pretty uneventful in a sun-exposed part of your body, but it develops tenderness, show it to me early because it could be a squamous cell skin cancer. That's not a bad way of helping out a patient without running late for your next patient.